Hey, I'm Catherine Wood. I am doing a population-focused interdisciplinary prevention plan on a heart failure clinic in rural Alabama. This is for Jacksonville State University's NU712 Clinical Prevention and Population Health course. So, like I said, the target population is going to be individuals living in rural western Alabama diagnosed with heart failure. Increased poverty is seen in this area, as you can see by the dark blue on the map. 20% of the United States population lives in a rural area. So this heart failure plan could eventually be promoted to other areas outside of Alabama. And studies have shown that living in neighborhoods with poverty segregation puts individuals at an increased risk of being hospitalized with heart failure and thus being readmitted with exacerbations. The risk factors for cardiovascular disease are going to be smoking, obesity, diabetes, and these are all three very prevalent in our targeted population. So it puts them at risk because they do smoke, they are obese, they do have diabetes. And living in impoverished neighborhoods, it puts people, like I said, at an increased risk of having this disease and actually having increased severity of symptoms. So what is heart failure? According to the Heart Association, heart failure is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. So you might hear about ejection fraction with heart failure. We're not going to go that in depth with it. We're just going to say you have heart failure or you don't. So heart failure, decreased heart function, it actually leads to malfunction of other body system, lungs, kidneys, and it is chronic. You can have exacerbations, which is going to be what you hear about, CHF exacerbations. Heart failure is usually classified by its symptoms. It's going to be classified by the New York Heart Association classification scale on a scale of A to D. D being those that are advanced heart failure, and A, you're just at risk. So this presentation is going to focus on people with level C and D heart failure, those who already have heart failure. This definition it really focuses on what we're going to talk about. We're going to talk about how heart failure is a chronic, progressive clinical syndrome that has a high prevalence of symptoms that lead to poor quality of life, high rates of hospitalization, increased medical costs, and high mortality. So why is this a problem? The high mortality, the decreased quality of life, the increased hospitalization, and the increased readmission rates. So mortality rates are directly related to the hospitalization. According to International Journal of Cardiology, heart failure is the leading cause of hospitalization in the United States and Europe. It's about 1 to 2% of all admissions, and that was in 2017, so the numbers are likely higher. And of those discharged after a heart failure admission, 15% will be readmitted within 30 days, and 30% are actually going to be readmitted within 90 days. So once you're in the hospital with heart failure exacerbation or heart failure, your chances of going back into the hospital and thus having a lower quality of life increase. So what are we going to do? We want to improve the quality of life, minimize the progression of disease, and decrease the hospitalization. So we are going to develop a tertiary level program. This is going to be our heart failure clinic. So randomized controlled trials have shown that by improving and teaching self-care of patients, the risk of heart failure related hospitalizations in general, and overall mortality can decrease and thus improve your quality of life. So this is the purpose of the heart failure clinic. We're going to teach individuals how to care for themselves physically, emotionally, hopefully resulting in decreased risk of hospitalization, decreased risk of mortality, increased quality of life. So in order to do this, we are going to monitor, we're going to educate, and we're going to provide. We're going to do this with the inspiration of the Optimized Heart Failure Program. So to monitor, we're going to monitor our daily weights. We're going to monitor our blood pressure, monitor dietary intake, and encourage telemonitoring. The symptoms of change, the symptoms of heart failure, that's what we're monitoring for. We're monitoring for blood pressure increases, daily weight increases. This means we're holding fluid. This is going to be the Optimized Heart Failure Program. This can be on your telemonitoring equipment. This is going to be where you do your daily weights when you're, I guess not daily, do your weights in the clinic. Do your heart rate in the clinic. Blood pressure in the clinic. And then it reminds you to look for these signs of volume overload. And reminds you to look for the potassium when you take those, or the creatinine when you take those. These are going to be your non-pharmacological measurements that you can look at, and the meds. So, diet, exercise, weight. These are things that you can talk to your patient about. And we have to look for detection of worsening symptoms. This is like a checklist for healthcare providers. It also reminds us, are our patients on ACEs, on ARBs, on beta blockers? Telemonitoring. This is the telemonitoring that I was talking about. This is where this is an app. This is best practice. This is weight monitoring. This is where they put their weights in every day, their blood pressures in every day. It has resources, educational resources for the patient on an app. This is part of it. So we're going to educate. We're going to educate on disease processes, self-management, self-care, symptoms of the exacerbation, like shortness of breath, increased edema. We want to improve the quality of life, and we want to modify those bad behaviors, the smoking, the obesity. So like I said, self-management is the key. Education is the key. We want to educate our patient to manage themselves, to monitor and track their symptoms, to interpret and recognize trends, and to take appropriate action when they see something off. Whether it's using the telemonitoring equipment, whether they're using a sheet of paper. We just want them to track, monitor, interpret, and take an action when they see these trends adjusting. We want to keep them out of the hospital. So the behavior modifications that we want to talk about are going to be restrict sodium, exercise, and really importantly, use our social supports. Use our family, use people to help us. Hey, let's get out and exercise. Having that knowledge of heart failure is going to improve symptom monitoring. It's going to improve the recognition of our symptoms and thus give us a response to our symptoms. Allow us to allow the patients to notify someone when something doesn't look right. So allowing patients to monitor their symptoms is going to give them the ability to notice a change quicker, leading to an increased likelihood that they're going to take action for these heart failure symptoms. And hopefully the result is going to be less hospitalizations and ER visits because they're not letting these symptoms get out of control. We're not having that CHF exacerbation because we do have that symptom response. So our resources for this interdisciplinary team, for this heart failure clinic, this is going to be your DNP, your RN, your social worker, primary care physician, dietitian. First of all, the role of the DNP is going to be to educate. You're going to involve the family. You're going to monitor your patient's medications, making sure they're on medications that optimize the fluid, that help them get the best quality of life. You want to communicate with your interdisciplinary team. You want to let the dietitian know if they're needed. You're going to have weekly follow-ups. The DNP is going to have weekly follow-ups with the patients when they're first out of the hospital, because as we know, that first 90 days, that is important. That is when we have to keep those patients out of the hospital. We need to keep them home in order to increase their chance of having a good quality of life, decrease that chance of mortality. We're going to have telehealth. The DNP is going to use telehealth to track those patients' changes in weight, call them in if they need to, and most importantly, we're going to encourage lifestyle changes using the 5 A's. So the 5 A's are going to be to assess, advise, agree, assist, and arrange. Assess your patient's motivations for wanting to make these changes. Advise your patient, being clear and specific on how to make these changes, on what needs to happen. Agree with your patient on the goals and the methods of the treatment. And we want to make sure our patient, we know why they're willing to change, make sure they are willing to have changes. We're going to assess them, assist them with self-help, give them additional treatments if needed. Do they need a nicotine patch? Do they need to have another consult? Do they need counseling? Do they need that community support? Do they need the food bank to help them find those less salty foods? And we're also going to arrange follow-up appointments, supports, and consults patients need in order to make these behavior modifications. So these are our barriers. Our barriers are going to be financial burden. We're going to see that in our poverty areas. We're going to see food insecurity, again, in poverty areas. And hopefully with the use of an interdisciplinary team, we can increase the social support, we can increase the health literacy, decrease the food insecurity, not worry about the finances as much, and get them the consults that they need in order to make these modifications. So our clinic is going to be successful when we see that our readmission rates are down. Our optimized heart failure checklist has been utilized, and our patients' knowledge is good about heart failure. We're going to use the Self-Care Heart Failure Index. The Heart Failure Index looks at whether your patient is taking their daily weights, maintaining this low sodium diet, being physically active, and their overall health maintenance. Most importantly, once again, their ability to recognize their own symptoms of an impending exacerbation. DNP competencies with this program are going to be communication and relationships. So we're going to communicate with the patients. We're going to communicate with the people that we're working with, providing information about activities, plans of the clinic. We're going to understand our coworkers, understand our patients in order to build these relationships with them. We're also going to work on change and project management as our competencies. Change, obviously, behavior change, facilitate these changes. And we're going to use all of our strategies, like the 5 A's. And then we're going to set our priorities for our project management, and we're going to coordinate with our employees. We're going to coordinate projects. So, in summary, our heart failure clinic, Western Alabama, individuals living in poverty, those at an increased risk of developing, or individuals who have actually already developed heart failure. We want to keep them out of the hospital by teaching self-management, self-care. It's going to be led by a DNP. We're going to teach the patients to monitor for symptoms and do something about it. We're going to use a social worker, a dietitian, a nurse. Most importantly, that DNP. Also, we are going to promote lifestyle changes. We want decreased hospitalization rates, decreased readmission rates. use our heart failure checklist, and improve our patients' knowledge.